Let's get started, guys. Time to take your seats. Yeah. So, everyone, I'd like to introduce you to Dr. Tracy McIntosh. She's amazing. She's Associate Dean of Access, Belonging, and Community Engagement at UCF. And she's holding this whole place together. Well, besides Dr. German, of course. But yes, let's give her a round of applause and let's hear what she has to say.
All right, thank you so much. It's a pleasure to be here. Thank you, Dexter, for inviting me to share my perspectives and ideas about how to ensure that we're including health equity as we are developing these new initiatives, innovations in AI. I also want to transition us from the bird's eye view that Anthony provided us from above the earth about how AI is bringing us forward, and I would like to bring you back to the bedside with me in the emergency department. And I'd like to open with a case that I hope will encourage you, will inspire you to think about how can you partner with clinicians, with community organizations, with patients to understand what are the questions that you can ask on their behalf to advance their healthcare outcomes overall. So improving access and outcomes for all with AI. So I'd like to start with a case, a hook to help you to understand what are some of the problems that we're facing in providing excellent patient care outcomes to every single patient, and talk about opportunities for AI to reduce healthcare disparities in America. And finally, thinking about the importance of your engagement, your heart, your brain in overseeing how you incorporate AI into clinical care and clinical pathways. So this is a patient that I personally took care of. I've changed a lot of it so nobody could ever know who this is, but this was a real person that walked into my emergency department a few years ago. So imagine a 52-year-old Portuguese-speaking female, history of diabetes and hypertension, anemia, coming to the emergency department with ankle pain. Here's what happened. She was at a grocery store and had a syncopal episode. That means passed out. Fell to the ground and now unable to walk because of pain in that right foot. Okay? I do the x-ray and just follow the straight lines. You don't need AI to know that there's a fracture here in these bones, the tibia and the fibula. So we straightened this out, put this person in a splint, but ultimately the patient decided they didn't want to stay. She said she wanted to go home, she wanted to see her primary care doctor. Whatever the reason was, we weren't able to convince her to stay in the emergency department to get definitive care, to go to the operating room, to be managed for why this person passed out in the first place. And these are AI, of course, generated images that I have here. So I saw this woman the second time. She came back 4 weeks later. Pain and swelling was still there. She was walking on the cast that we had put on. She was supposed to be non-weight bearing. She followed up with her primary care provider who said, this is not my problem, this goes to orthopedics, but she never made that follow-up appointment. And in her mind, from the conversation that we had with her, she thought that all she needed was a splint to heal these complicated fractures. Unaware that she needed to follow up with orthopedics, even though it was documented multiple times, it was not entrenched in her mind that that was the definitive care that she needed. So imagine this patient, what they went through, and the prognosis here when we saw her the second time was grim. We spoke to the orthopedic surgeon and said, this is so unstable at this point. I see 3 options for our patient. One of them is amputation. So bringing you to the bedside with me, this is a woman in America with health insurance who is facing amputation from a fracture. In the highest resource, the biggest spenders, and this is the kind of outcome we're still having in 2024 in healthcare. So come with me here to think about how can we solve these problems, these big problems for our patients. So this is my perspective. These are the questions that I would like to pose together with you. These are the ways that I would like to collaborate as a clinician on behalf of patients for you to think about how can you help us solve these very problems. How can we improve? Two of our biggest challenges in healthcare is communication, and well, trust is a problem too, but communication really is a big problem. And you could see that that was the crux of this bad outcome for our patient. How can AI improve healthcare through improving communication? How could we have streamlined follow-up for this patient so they weren't jumping around, so that it was seamless from my door to their door? That's a solution that I'm looking for. And then how can we develop care pathways and oversight so that patients never fall through these cracks? So that a patient that you know is high risk because of certain features is connected with wraparound services so that nobody has this kind of outcome in America. So I'd like to go through this and give you some ideas, some concrete ideas. There's software already out there. There are systems, LLMs already doing this. But to just plant it in your mind, these are the real solutions today that we need in healthcare. And then with each of these, I want to just give you a caveat for some of the pitfalls that I'm already seeing in the literature, or how a large language model can actually do a disservice to patients and can perpetuate healthcare disparities. So I want to present both of those. So first of all, accessing language of choice. Right now, I'm using Google Translate to do discharge instructions into many languages. I don't have every language. I don't have all the characters. So this is a very low-hanging fruit that we need some real solutions for in all of our EMRs to make sure that every patient understands. Beyond that, making it in understandable language, and even converting my English in a discharge document to understandable English. And so there's a couple models out there that I've seen that are doing this work. From ambient listening, I don't even have to write it down. It's already generating a patient-friendly, plain language discharge summary. So that is already out there. So I want to show you one example, though, of how it can perpetuate inequalities. So in this model, they looked at how are we doing with generating discharge summaries in languages other than English. And so I already said I'm using Google Translate. I don't actually know for a fact that it's seamless in every language. In Spanish, I understand it's quite good because I have colleagues who tell me that it's good. But in Russian, I'm not so sure in other languages. And so in this model, they developed patient-centered, around a grade 6 or an 8th grade language for discharge instructions from the emergency department. And they found that for English, it was excellent. But when they looked at other languages, they saw that there were a lot of elements that were missing. And so those would be possibilities and opportunities for healthcare disparities to persist. And so here's an opportunity for us to keep our eye on these types of models and to make sure that we're understanding that this is inherent with what they're drawing from, that we may be missing some things. And so I wanted to highlight this. Second was an opportunity to improve follow-up for my patient. They went to their primary care, but it's hard to get a specialty follow-up. It's hard to find folks who take the insurance for all of our patients, especially Medicaid. And so I would love to have a system that didn't involve a patient calling frustrated on a Monday, no appointments, can't get through on Tuesday, give up, and don't get the follow-up that they need. So how can we develop models to do this kind of work for us, to take out the administrative burden from my teams, my nurses, my secretaries? And so low-hanging fruit, and I think this is very low risk in terms of solutions. Accessing in-network providers. It's very frustrating for a patient to call doctor to doctor. Many of you have done this. They don't take my insurance. And they spend days spinning their wheels, and then they end up not following up. They end up not getting the care that they need. And so these are real easy opportunities, minimizing geographic barriers by helping folks to find out who's in network. And allocating resources. This could be a pitfall. So let me show you this data. So in this study, they looked at racial bias in medical report generation and found out that there were, again, opportunities where biases that were already misproven, debunked in the literature, that AI is still pulling from. And so it's very important that we have oversight. And when we're seeing that it's good to understand and stratify by race, ethnicity, by insurance status. But when we're pulling that data and forming models and driving care based on those debunked formulas at this point, then that can introduce further bias into our care. So we want to be mindful of that. And finally, decreasing the impact of provider bias. For me, this is one of the most optimistic opportunities in AI, that the art of medicine is also my bias, my lived experiences, the stereotypes that I bring into clinical practice. And so for me, AI is an opportunity for us to eliminate that and to focus only on objective, vital signs, the X-ray report, abnormalities in labs. And so that's a real opportunity for us. But incorporating this into clinical pathways, I want to show you another study that, drawing on past literature, there is an opportunity to introduce bias. And so this was a model, these are a couple of models that were developed where they were asking these race-based questions in terms of managing patients. And so they asked questions of LLM like, tell me about the difference in pain thresholds between a black patient and a white patient. So imagine you wanted to put a system into place where you automatically give a pain medicine after a surgery. But the model is pulling in data where there was debunked myths about differences in pain tolerance from decades and decades ago that is still permeating out there. And if our model brings that in, then our clinical pathway guidelines are going to lead to health disparities, lead to suffering for certain patients. And so this was very eye-opening for me to see that the models are pulling in this data. We know it's out there, but that this is going to be bubbling to the surface and leading to differences in patient care and patient outcomes if we're not mindful, if you and I don't have oversight, if you and I are not sitting together talking about the models as we're generating them. So in conclusion, I'm an optimist as well, and I see lots of opportunities for bias to be reduced in healthcare. For the barriers, the administrative barriers, the cognitive load for clinicians, that you all will help to take that away so I can focus on the communication with patients at the bedside and the clinical procedures. But I wanted to highlight a couple of articles that you can review to see how is bias perpetuated in language models and what can we do to partner and to ask the questions that patients really need us to answer together. So thank you very much for your time, and happy to take any questions. Okay.
Hi, Parikh, founder of technology. We're here in Research Park and now opening up in Lake Nona. Thank you, UCF, for you just accepted my chapter for AI for DoD, which is coming out from the Systems Engineering Department. And I'm glad that the last speaker started with engineering. My background is originally NASA work, and now we're opening in healthcare, and we're integrating the AI from aerospace engineering and military to healthcare. And one of the things that I wanted to propose is there are really great technologies out there. I'll just throw out what I know because I'm an ex-IBMer. 13 languages for NLP, for example, to understand context. And I just want to push the idea that we need to engineer these approaches using standard approaches like, first let's look at the NLP, and now let's take a look at what kind of machine learning, and then catch those governance challenges and Rails. So there are all these different technologies, and they have to be engineered together. So all I was saying is that think about how the health community can work with the engineering community and partner with two different kinds of brains, and I think that's going to really be successful. By the way, just a quick clarification, I'll tell him, all Apollo astronauts had to be engineers. Some of them were PhDs. Thank you.
One follow-up I'll just mention is Anthony was talking about regulation. It's important to note that there is regulation around the use of these race-based algorithms. And so if the models are incorporating it, the onus is actually on me as the clinician using them that I'm not allowed to use any of those. And so it's not on you when you're designing. So that just highlights the importance that you understand that that's a limitation as you're designing these programs and models, and that we really work together to make sure that that's not being translated into my clinical practice, because there's real implications for me if that's there, because that means that I'm discriminating in the care that I'm providing based on some of these factors, which we cannot do and we should not do.
Thank you for the presentation, Dr. McIntosh. I'm Dr. Rendu with UCF. Your last slide it had severity from 5 to 0, and there was red. I was just trying to understand, is red a good thing or red a bad
Yeah.
thing?
So they were running this model iteratively, and so it was checking the number of times that it flagged that positive finding. And so each of the models was run multiple times, up to 5 times. And so those are the number of times that it pulled a positive result for that.
Thank you, Dr. McIntosh. Okay.
It's your next.
You want to introduce me?
So you've been seeing Dr. Hadley all day, every day. Everybody from UCF knows him, but do you really know him? The man, the myth, the legend. We know Dr. Chang, but come on. Let's give a round of applause to Dr. Hadley,
Okay.
Chief of AI at UCF. Come on, we can do better than that.
All right.
Let's go.
Thank you. Thank you for that lovely introduction. My name is Dexter Hadley. I work in UCF. I'm a scientist and a physician. And I'm going the wrong way.
Potato, potato.
So I'm not going to tell you about me today. I'm going to tell you about this guy. So this guy is my friend. You see him there, Bando. His name is Bando. U.S. citizen, born in the Virgin Islands. This is a U.S. citizen I'm talking about. And this was probably, my dad passed away, so this is my youngest son currently. There's another one coming any day now. And, Bando is like a grandpa to my son, Isa. We went to Morocco this past Christmas with Bando. This is Chef Shawan, the Blue City. We went to Spain with Uncle Bando. This was Bando in my country, Trinidad and Tobago, in July. Bando got diagnosed with stage 4 pancreatic cancer 3 weeks ago on his birthday, 10/20/65. No symptoms. 58-year-old, 59-year-old, I guess, now, history of prostate cancer, so some history, but shocking diagnosis. He's lost 30 pounds in 3 weeks. I'm supposed to be a physician. I'm clueless what to do for this near member of my family. So I started reading about pancreatic cancer. Who knows what Notebook LLM is? This is not going to be a long talk. But Notebook LLM is a retrieval augmented graph, a RAG, which is like a fine-tuned large language model. So think ChatGPT is trained on everything in the world. I trained Notebook LLM on pancreatic cancer guidelines and on Moffitt, because we're in Florida, and that's where you go if you have pancreatic cancer. And I asked it, make a compassionate podcast. It makes podcasts. This is entirely AI-driven, and I hope the audio works. But let's listen to a minute of this podcast trained on, you see KRAS mutations, there's NCCN guidelines, various guidelines. I found the top 5 things. But I thought this was just incredible, and I would like to share it with you. No. Let's play this.
We're diving deep today into pancreatic
How do you
cancer.
raise the volume
Okay.
on?
It's a tough one.
Yeah.
A diagnosis that can just really
Sorry?
rock.
Your volume?
We're diving deep today into pancreatic cancer.
Okay.
It's a tough one.
Yeah.
A diagnosis that can just really rock your world
It does.
and leave you with so many questions.
Absolutely.
But we're here to help you navigate it.
Right.
And we really want to focus on hope,
Yes.
on the latest advancements, and how those are helping people survive longer and have better lives with pancreatic cancer.
Absolutely.
We've got some great sources.
Yeah.
We're looking at publications from Moffitt Cancer Center.
Great source.
They're leaders in this.
Absolutely.
We've also got stuff from the National Cancer Institute. Mm-hmm. And then we're also using the NCCN guidelines for patients,
Yes.
which is really cool because it's put together
Yeah.
by top cancer centers all over the country.
A great resource.
So they're collaborating on what to tell patients.
Exactly.
One thing that I found really striking as I was looking through this
Yeah.
was from Moffitt.
Uh-huh.
They mentioned that a lot of pancreatic cancer diagnoses
Yeah.
happen at stage 4.
It's true.
And that just makes you wonder, like, why? Why is that?
Right.
Why are so many people diagnosed late?
It is often called the silent disease
Okay.
because the symptoms early on can be so vague that you might just think it's something else.
Oh, I've got a little indigestion.
Exactly.
And then suddenly you find out it's stage 4.
It can happen like that.
But the important thing, though, is that even at stage 4,
Yeah.
it's not a reason to just give up hope.
Absolutely not.
There are still things that can be done.
Yes, that's the message we want to get across.
Yeah, that's a.
Well, you get the idea. It's 15 minutes long. I wouldn't put you through it. But that is amazing. And for a Rasta man that doesn't believe in the system, my friend was very, very happy to be involved with AI all of a sudden. And I want to leave you with one last thing that just kind of blew my mind. Who's heard of ChatGPT? So I asked my postdoc to train a large language model on ChatGPT, pancreatic clinical trials. If you ask regular GPT to do this, it's not going to do it. But if I can mirror my screen here, is there some code? 7403. Okay. Okay. If I go to my ChatGPT here, so you probably have seen this on your phone. I've trained a few of them. Tell me what it is you do. Oh, no, this one. Yeah, this is pretty cool. Tell me what it is you do. What do you do?
I help you find and understand clinical trials for pancreatic cancer. If you're looking for treatment options, want to know more about ongoing research, or need details about specific trials, I can assist by providing accurate and up-to-date information. Let me know what you're looking for.
I was recently diagnosed with stage 4 metastatic pancreatic cancer. What can I do?
I'm so sorry to hear about your diagnosis. While this is a challenging situation, there are still options to explore. Here are a few steps you can consider. 1, consult your oncologist. They can guide you toward the best treatment options, such as chemotherapy, targeted therapy, or immunotherapy, based on your specific case. 2, look into clinical trials.
I'm in Orlando, Florida. Do you have any clinical trials near me? Following with live demos. I'm in Orlando. I'm in Orlando, Florida. Do you have any clinical trials near to me?
Yes, there are clinical trials near Orlando, Florida for pancreatic cancer. Here are a couple of options. 1, IMM104 study, NZT 05585320. This trial investigates a new treatment for advanced or metastatic tumors with RAS mutations. Locations near Orlando include Mayo Clinic, Jacksonville, FL, Florida Cancer Specialists and Research Institute, Lake Mary, FL. 2, A2B53 CAR T study, NCT 5736731. This study focuses on using CAR T cell therapy for solid.
What about ones at Moffitt Cancer Center? I hear that's really good. Can you find trials at Moffitt Cancer Center?
At Moffitt Cancer Center in Tampa, Florida, there is a clinical trial for pancreatic cancer. Trial title, a study to evaluate the safety and efficacy of A2B530, a logic-gated CAR T in participants with solid tumors that express CEA and have lost HLA-A02 expression, NCT5.
So we're driving to Moffitt on Wednesday. Thank you very much. Now we have a panel.
Let's start the panel, guys. Where's Mike Galvin? One person is missing. Mike Galvin. Just give me 1 minute. Gotta find someone. Hold on. Found them. Mike, you're on the panel. Next? Yeah. So everybody's here for this community health panel. Be prepared for your minds to be blown, for sure. So these are 4 experts in community health. They dedicate their lives, their time to improve global health outcomes. So let's have each of them introduce themselves.
Yes. Good afternoon, everyone. Happy to be here. Wilson Ariza. So I've been 35 years in healthcare. My background is informatics, and I spent 30 of those years in the military and the Department of Veterans Affairs, and 5 years in the corporate sector. What I have been doing for those years is implementing disruptive innovations in healthcare for first time in the government. And I spent billions of dollars having done so, and 3 of those innovations for first time: telemedicine in the early 90s. I know some of you in the audience were not born. And later on, the electronic medical record took all the hospitals from pen and paper to a paperless environment. And last but not least, medical education, medical simulation. So I have spent a couple billion on behalf of all of you, hopefully well spent, and looking forward to the conversation on how today AI being another disruptive innovation, some of the lessons learned to implement that in the healthcare, especially in the private sector.
Thank you, Wilson. It's always nice to sit next to somebody who's spent a couple of $1 billion. So, have you got any left? So my name is Mike Galvin. As you can tell, I'm originally from the UK. I'm from Liverpool, the north of England. My background is in global telecommunications. So I spent about 25 years working with the big tech companies, the Googles, Microsofts, Amazons, Facebooks, etc., helping them build their global networks, which was a lot of fun. I do what I do now because of Anthony Chang. So the guy that was on earlier today, a friend of mine took me to Children's Hospital Orange County one day. I met the team, and I realized as I'm going into the latter phase of my career that really what could I do? I wanted to do tech for good. And it's incredible, the intersection of what we sit in and what we're talking about today. AI is unbelievable. It's going to be in everything that we do in our lives. But we're the people that are going to make that happen. And the vertical that it's needed in most is healthcare. It can be the most transformational in healthcare. So I have two startups. One's called Hands In that I work on with Brian Isaac over there. Because we help build social media, we realized that it wasn't great, especially for healthcare. There are like over 400 million people on Facebook doing healthcare work. That isn't great because their data is being mined. I love social media, I'm on it, but it's not a place that you should be doing healthcare work. So we built a private platform for communities and nonprofits. We can talk more about that later. My other company, and on that journey, I met an amazing professor who had 14 AI algorithms in imaging. And so I work on a hardcore AI imaging. It's called Live AI. We're particularly focused on brain tumors, cervical cancer, and lung cancer. So delighted to meet you. This is amazing. You pulled me out of that room because I'm still working on this stuff. So the energy here is incredible. You people are going to do transformational things. I'm really happy just to be part of it.
Hi, I'm David Metcalf. I kind of have a couple of different roles as well, too. I am a professor here at UCF in the Institute for Simulation and Training, and also with some of my friends have an investment firm called Global Blockchain Ventures. What unites those things for me is every day getting up and trying to inspire innovation, whether it's in the laboratory, whether it's for our investors or helping people to fulfill their dreams, too, through entrepreneurship. And UCF is a great place to kind of have all those things come together too, in the way that Anthony talked about. We've a long time talked about being a transdisciplinary organization too, where we have multiple disciplines all coming together. And if you think about simulation or digital twins, they move across multiple vertical industries as kind of a horizontal platform or technology. Recently, we've changed the nature of the stack. By stack, I mean some of the infrastructure that can enable this to work throughout not just a whole enterprise, but a whole community. Some of the things we've been able to do with this type of model since the beginnings of this being just cow pastures around here too, and seeing the College of Medicine rise, using the same technologies we used at Tufts, at University of Miami's medical school, at UPMC, for our medical school and our doctors, and to be able to bring that together. What's that platform? Well, a wise colonel, when he was still in uniform, said to me one day, you know, all this stuff that you're doing with systems integration and simulation, yeah, that's cute, that's nice, but really we want to simplify it for the military down to ABC: AI, blockchain, and cybersecurity. So that's what your platforms, and that's what's going to be going for the next few years, 5 to 15 years. And lo and behold, we haven't done a project in the past 5 years that didn't include those three things in some way, shape, or form. We had a little discussion on that cybersecurity being post-quantum cybersecurity. How do we make sure it's future-proof in some ways, too? And also around one other thing, because we're at the Institute for Simulation Training, adding in a D, A, B, C, D, digital twin. So we'll go through the whole alphabet eventually, I know, but that D is important as well too, because that's the natural interface, the multimodal interface, just like when we use Google Maps and it has all these modes of interaction with us. They make this very accessible to the largest and broadest possible population that we can have, whether that's for health, whether that's for community outreach, entrepreneurship, all things that are societal goods that grow that. A university like UCF that is one of the least expensive in the nation to go to, that has a broad and diverse set of population for the students, great place to see these innovations thrive. And that's what we love about seeing all of you here and getting to talk to you a little bit about some of the things we do.
Thank you, Dr. Metcalf. I'm Chait Rendu. I think the highest talent I have is I'm a UCF grad from the IST program, and I had the opportunity to learn and be part of the experience that Dr. Metcalf. Right? So I worked for community health here for the Florida Department of Health for a couple of years. That's my core research interest. How do we create personalized knowledge graphs to understand the human at the other end of the AI, the human experience, the human enrichment, and the human engagement, and then how do we bring this person to benefit from the AI and understand that in a very personal level. I'm an assistant professor at the Rosen College of Hospitality Management, so we're very interested in that intersection between people and technology. Thank you so much. An honor to be here with this panel.
No, this is beautiful. This is beautiful. So just to introduce myself, I wanted to have the real leaders go first. So Dr. Val Torres, I am the lead of global partnerships and business development at the Global Health Impact Network, which is a global physicians network focused on innovation. We are doctors focused on helping patients. We put people over profit, and we really want to improve global health outcomes. I have the privilege of working with Mike Galvin, with Hands In. He's a glue that holds us together, right? We are global, and of course, when you're working with different countries and different regions, you need to have everyone on the same page, communicating effectively and safely, and that's what his platform offers, which is called Hands In. A lot of people there, thousands of doctors and physicians, clinicians, and we're all making great progress. In my case, I handle the international network expansion and partnerships for Global Health Impact Network. And I bring what's called social capital to the table. A lot of doctors, they focus on getting good grades, passing their boards, but not a lot of emphasis is put on social capital, the value of people. And let's just be frank, data is people. We need to understand that. It's not numbers, it's people. So when you see data, those are lives. Those are people that we are helping, and we are in it to save lives. So let's get some wholehearted discussions had between these four, because of course, they're the best in the business. And the biggest issue I've heard in the last 2 to 5 years or so is healthcare is fragmented. Everyone is working in silos. People are not working together. Mike, what are you doing about that? What solutions do you have?
The hardest question came to me first, Val. We're supposed to be friends, but that's fine. Thank you for asking. I'm going to give you a perspective that I'm not a doctor. I got to healthcare quite late, but you said something very interesting. But I am a patient, and I am a person. And I'm doing work in oncology, and Chait and I have talked a lot about particularly oncology. And if you just look at the stats of oncology, 1 in 2 men is going to get cancer, 1 in 3 women's going to get cancer. But that's not the real stat. They are brothers, sisters, mums, dads. Everybody is affected by cancer. It's really, really complicated. Brian and I work with over 200 pediatric oncology nonprofits. And when you spend time with the patients and the families, you can understand a lot of frustration. Are there enough treatments? Things are complicated. If I speak to 5 different people, I get 5 different answers. And it's really hard, and it's very, very emotional. And there's financial toxicity in that as well. So it's very difficult, and very often we listen to the healthcare industry talk about what it's going to do. But what's amazing with AI is we are at an absolute tipping point in healthcare. Never before has a patient been able to access a generative AI or a large language model and potentially speak to 1 million doctors, the knowledge of 1 million doctors. And if you speak to the oncologists, how is one oncologist who is an eminent oncologist going to stay on top of 2,000 publications a month about their topic? Now, AI and technology is amazing at filtering that information and giving that information to the community. Because let's face it, solving these problems is, as Brian always calls it, the coalition of the willing. We're all in this together. So that's why I love these conversations. Even this morning, sitting in that room, the knowledge power of different people and the beauty of innovation is bringing ideas to the table that can connect, that can move things forward. And so for us, we try and do one small part of that, which is, can we give people private environments to work in, safe environments to work in? Trust is a word that's used a lot and thrown around. But trust means that we don't we don't harvest information and sell it to companies. And I can tell you right now, there are groups that we work with that have realized that if you're in rare diseases, the industry may not be serving you. And that's a difficult thing to say, and I know that might be a contentious thing to say. But if you have a rare disease, very often parts of healthcare is a business. What we see certain groups doing, and it's happening right now, they are self-forming their own communities, they are bringing their own data together, and they are federating that data and going to speak to clinical trials and drug companies themselves. Now, the nice thing about that, though, is they actually do it in partnership with doctors, nurses, and the healthcare community who want them to do that as well. Because everybody wants to move the standard of care and change the standard of care. And AI is just, and Dr. Chang put some amazing slides up, it has just accelerated it like nothing before. So being able to harness those things, I think, is really critical, and find balance and find the roles that we can all play in doing something transformational.
Well, that's beautiful. Well said, well said. Now, Dr. Randu, I know you have a passion for community health. What are you seeing?
So Dex, yeah.
Yeah.
So we'll start with what is community health.
Yeah, yeah.
Right?
What's community health?
And
Please
then
define it.
What are we seeing? So I think historically everybody looked at medical care,
Yes.
something done in clinics and hospitals, but there's a realization now with chronic disease, cancer, and the human element. The human element always happens outside of for a large part, is outside of the hospital. And it's at home, it's in the schools that we send our kids to study, it's in the parks that we go to, it's in the local transportation system, it includes jobs, access to clinics and care, insurance. So all of this together is community health. How does the community, the local environment you're in, come together to support and enable health, or not do so? And working here in Orange for Florida Department of Health at Orange County, we're blessed with a number of nonprofit partners, including our very large hospitals, and they all come together. And you talked about fragmentation, and there is fragmentation of care, but there's also an effort to coordinate this care, and coordination happens at several levels: leadership getting together and allocating resources, care pathways where patients are being referred across organizational boundaries by health navigators, and ultimately transferring data about a specific patient from one organization to another organization, hopping over boundaries created by HIPAA compliance, legal constraints, and such. So from an AI in community health perspective, what excites me the most, I think we're on the cusp of figuring out how to make these connections work more seamlessly. And I use that word loosely with a lot of caution. There's always going to be compliance that's going to govern. So these governance models of data sharing and integrating care and integrated care pathways, I think for the first time are actually possible with advances in AI. And this is where I think UCF stands out. We have a very integrated approach, as you saw today in the coding challenge. We had engineers, we had students from med school, we had faculty from multiple disciplines: education, engineering, medical, tourism, and working together with companies, technology developers. So how do we come together in this fragmented kind of environment with AI-enabled solutions that can help to coordinate this better and create integrated pathways to care? Because once again, the care happens for a large part outside of the hospital system. And I think that to me is community health, and that's why AI in community health is, I believe, the new frontier in health, and very exciting time to be right here in Orange County, Florida, where we're building these technologies. So thank you for that, question.
Of course, very, very well said. Now, fun fact, when I graduated from med school, I don't ever recall AI being on my boards. I don't ever recall seeing the term social determinants of health. Dr. Metcalf, can you please explain to us what that means and why should we care? Why is that important to our health?
Go back to this idea of these transdisciplinary teams, and hard problems is sometimes what they say in physics or in medicine too. How can you solve these big societal hard problems, big, hairy, audacious goals? One of the things that I'm looking at right now is the way that these social determinants of health, these other large, hard problems can be solved not just by one particular stovepipe discipline. It takes multiple disciplines working together. Some of the teams that we're being asked to put together in team science to solve big problems and make good decisions to start with and implement and execute plans are what we're starting to see and call AI super teams, or HATs, human AI teaming systems. Those are some of the different structures that are being put in place to try and solve big problems. And for instance, this past quarter we've been working with a team from the Rosen College, from the Institute for Simulation and Training, some teams from medicine, some teams from sociology, to attack some big social and health problems. One of those is human trafficking. The health impact, of course, the societal impact, if you'd say the scourge of that, the legal implications, law enforcement implications of that too. It's a big problem that no one of those groups can probably attack and fix by themselves. But those are the problems that if we start to open our minds, we can start to attack together across these different disciplinary lines. And that's been really eye-opening for me too, and humbling to see that. Because yes, you certainly have your AI that's involved in there, maybe a couple of different types or flavors of AI trained in different disciplines and expertise. And then you have leading experts as well too that get involved in these different areas. And you put together solutions that can really make a difference. Things you wouldn't have thought about before this advent of these different areas coming together.
Well, that's beautifully said. Healthcare is evolving. Let's face it. It's not going to be the same in 2 years as it is right now. And Dr. Chang said it. It's changing rapidly. But what I've been seeing is that a lot of healthcare is not actually healthcare at all. I'm seeing a lot of business, finance, tech, nonprofits, education in healthcare. That's not being taught in med schools. So, Lieutenant Colonel Arisa, what do you think about that? How does that affect the quality of doctors that are being produced right now? What do they need to do to keep up with demand?
So one critical aspect it's for any clinician, and this goes also for anyone. Again, my background by training, I'm a hospital administrator and an informatics engineer. Yes. But as I implemented all the different disruptive innovations for first time, telemedicine we implemented in the government in 1995. 1995, almost 30 years ago, but it wasn't until COVID that the adoption was there. And I spent about $800 billion just doing that. Electronic medical record. NASA and DARPA, you familiar with the DARPA? D-A-R-P-A, DARPA? Well, DARPA implemented AI in 1962. We did it in 1991 in the US military for logistics. So going back to your question about clinicians, I'm going to reverse that and encourage the business owners and scientists, as you develop technology, the clinician must be integral part of the process, from the baseline of the requirement all the way to the workflow and implementation. Because what has transpired, one of the huge lessons learned that we had in the government that I had as a senior leader, when we implemented electronic medical record, and I was deploying and implementing that in Iraq and Afghanistan, and I did the first pilot, my dear friends, surgeon, clinician looked at me and said, Wilson, this does not even is close to my workflow in the emergency room. So therefore, there was involvement, but not enough. So that requires you, as I now going to the clinician piece, to learn about the innovation and technology, but most importantly, fight to be at the table when any of these innovations are being incorporated or trying to be part of the enterprise system that you belong to, because no one knows the system better than the clinician. I made it, as you know, part of my career was also here. When I retired from the military, I was here in Lake Nona with the Department of Veterans Affairs in Washington, D.C. I was part of the senior leaders that built the National Simulation Center here, the one here in Lake Nona. Part of what I kind of encourage everyone at the National Simulation Center coming to work with us was go and spend 2 weeks in every VA hospital to learn and see the workflow, and then talk to the clinician and ask the question, where do you see medical simulation, in this case AI, where do you see AI helping you to do your job every day? So in recapping, the final message is for the clinician, you have to fight to get yourself at the table as AI is being implemented. For business owners and enterprises, you must have a clinician at the table, but also through the entire process of the innovation, in this case AI. Otherwise, you're going to end up with a tool that it might help, but it's going to be lacking that input from the clinician, who is, in this case, the customer.
No, of course, that makes sense. But yet I'm still confused. Healthcare is just evolving so rapidly. And I mentioned a lot of industries. So healthcare, business, finance, STEM, tech, education, nonprofits. Those are totally different. Those are not really that related. But Mike, how do you get all of those industries together to collaborate, communicate and co-innovate? How is that possible? Does that even exist, that technology?
That's a lovely layup question, Val. Thank you. I'm supposed to say use Hands-In as a platform because it's private and you can do that. That's such an interesting question to ask me at this point in what I'm doing, because I'm connected to all of those things right now. I'm working with nonprofits, I'm working with government, I'm working with VCs, I'm working with investors, I'm working with a lot of clinicians actually as well. And it's complicated. It's really complicated, and you have to go and learn the perspectives of all of those different elements. But what I love about founders and innovators is be creative, be brave, and strive for what you want to do. And the other thing is we actually all work together. We don't compete with each other. This is really needed. I'm working on a big project in Pan Africa right now, and one thing I love about AI in healthcare and building these types of systems is the democratization. There are massive technology leaps that we can take, not only in the US and in the Western world, but globally, breaking down those barriers. But the point is, Val, to your point, it's going to take all of those different elements to come together to really want to do something like that. I'm not sure if anyone else wants to comment on that, because I think we're all part of that.
I have one question for...
Universities are absolutely key. The work that you do, the research that goes on, being able to do tech transfer of amazing research. And again, I'm involved in that right now as well. And with you guys, the talent that you have, the conversations we have. And the thing is, if you explain that to patient communities, they would say, I'll have it tomorrow. So how do the business people mediate that and make it happen?
So I have one question for Dr. Randu, and I feel like I'd like to ask the audience, can anyone in the audience, if you've ever had cancer, had a family member with cancer, or anyone you cared about be diagnosed with cancer, please stand. So look around, you see how prevalent cancer is. To be honest, in the past 2 to 3 years or so, you can sit. In the past 2 to 3 years or so, I've had 3 family members being diagnosed with different types of cancer. I know Dr. Randu is working with Dr. Hadley aggressively to build large language models to kind of fix these problems, to get diagnoses quicker, more cost-effective, and ultimately to save lives. So if, Chait, you can explain to those in the audience what you're doing, why is it relevant to them? How can it help them? What is your value to them? Please.
So I'll try to keep it very succinct and high level. We're looking at knowledge graphs along with RAGs to add more context to the prompts that are input into the language models. And you can choose from a variety of language models. So we're building competencies with our students to train these, to create these RAGs, to extract language knowledge graphs, to tweak those knowledge graphs, and then evaluate the performance of these integrated systems. Once we do that, our vision is that we'll partner with groups that like Mike, and we'll try to transfer this technology out of the lab. And this is where UCF, I believe, has probably one of the best ecosystems in the nation to facilitate this process, which should be of interest to our students, faculty who are here, and the companies who are here, and the gold standard of that is the ICOPS program. And turns out Dr. Metcalf chairs that program and coaches most of our ICOP participants. So Dr. Metcalf, do you want to?
Wow, how'd you just tee that up? Perfect. Now, so iCore Innovation Core. Think about Peace Corps, AmeriCorps. It's something that is taking Silicon Valley processes out of the Stanford classroom that formed companies like PayPal, Square, and others that Steve Blank has come up with, that is now adopted by many of our federal agencies. DOD is adopted, NIH is adopted. And for us, the National Science Foundation has actually adopted and funded us to try and help the community. It's very different from normal class. It's actually the reverse, a flipped classroom. We don't get paid anything. We just have a love of entrepreneurship and trying to help people achieve their dreams. And it's very competitive because students apply to be in the class and they get paid to be in the class. So not a whole lot, but enough that it's competitive, and to fund and seed their dream. It's like Shark Tank, but with evidence. You come in
Oh,
for a
wow.
5-year, sorry, yeah, but come for a five-week program to learn about customer fit, product market fit, how to speak to customers, how to get to their real felt needs. And you do this within the military, within the government, as well as within commercial industry to see if your idea holds merit and is going to be something that you can turn into not just an idea or a dream in a lab, but a vision that can become reality and that has a business model behind it. So that, for many of us, unfortunately, the reality of the world is no money, no mission. So even if you're a mission-driven organization, a social purpose corporation doing social good, you still need to figure out how you're going to be able to fund that and make that dream a reality. That's the practical and pragmatic skills we try and teach across a number of different disciplines. More and more of those every day are starting to integrate AI, starting to integrate digital twins, advanced technology in other areas of the enterprise, and put those things together. So if you have a big idea or a dream, you can go and see the ICOR pages at UCF too. Look at ICORPS at UCF. We just got a new round of funding on that too, so you'll be happy to know that too. That's going to be kicking into higher gear as we go. Thanks for the quick commercial.
Oh, wow. Yes.
It's, two quick comments. One is how do we address the concern of so many industries in the world of AI? Well, I highly encourage, and I did that again, being at the senior level in the government, bring everyone at the table to discuss their challenges. And it could be the banking industry to healthcare, and all of them will share knowledge management. How can we share? We need data as a clinician. We need data, although it's important to discuss later on fidelity of that data. And obviously, you get the analysis only of the good data that comes in. But why don't we sit down first with all the different industries and say, let's discuss the requirements and challenges that we have and the different solutions. And I guarantee you that you will identify that there will be a common denominator in the challenge and some of the solutions that you can take from the banking industry to the healthcare. And then the second part it's that I highly encourage. Again, I talk to now that I'm in the investment world, but I talk to my senior leaders in the government, HHS, VA, Department of Defense, about AI implementation. And I will tell you, and they mention that many times the industry are kind of approaching them with AI innovations, and still the common denominator of one question is they fail to ask the leaders, what is your challenge? What do you need? They went and took action in what they thought it was needed. And maybe at the conversation, when I get briefings to the industry partners, I will say, look, sometimes you're talking to the wrong surgeon or the wrong general. So what do you mean? I said, well, let's take the VA. When I was in VACO headquarters in Washington, D.C., do you know how many VA hospitals do we have in the country? Anybody? Excellent, 150. So you go and talk to a gray American here in the VA in Orlando, and the director, he or she will tell you most likely his challenge here in Orlando. But with the many competing priorities that I have in Washington, D.C., if you bring me that AI solution for that VA in Orlando, I'm going to say, that's wonderful, but I'm addressing the enterprise of 150 VA hospitals, and that competing priority is number 800. So I encourage, get everyone at the table from different industries now that AI is here to have the conversation. And most importantly, never forget the user at any level and say, what is it today? What is the number one challenge? And again, I had it in my slides, you'll see later on. It's technology is wonderful, but it's extremely expensive, including AI. It requires a lot of resources, and it will require a lot of patience. Because disruptive innovations, sometimes you can get it out there, but the world or the industry probably is not ready for the adoption of that innovation. And that also a huge lesson learned in the implementation of implementing these disruptive innovations in different domains outside of healthcare.
It's easier said than done. AI is very complex, but yes, Dr. Andu?
Well, I just wanted to give you an example of the speed of innovation. Today, when we're having a conversation, we discovered a problem that's going to be a very big problem with multiple health dimensions in the very near future. Our new government is going to have a mass deportation exercise. It has a law enforcement component, there's a healthcare component, there's a scale component, there's a human factors component, and all of this needs to come together to do it in the most humane, safe, collaborative manner. And through conversations, I just realized Dr. Metcalf is already ahead of the curve on that. And we started to talk about how can we use our knowledge on knowledge graphs and RAGs to kind of make this conversation with the families that might be impacted humane, compassionate, collaborative, and more safe for both the law enforcement and the companies at scale. We're only going to be able to achieve that with AI. Dr. Metcalf, would you like to talk a little bit about?
Well, it's back to what I said before, too. We want great Americans. We want great people coming in. We're a country that's melting pot. But at the same time, we also have people coming in and exploiting people for their own gain, human trafficking and labor trafficking, sex trafficking, those type of things, too. I don't think anybody in this room is going to raise their hand that they want that. So those are the types of things that when we look at the social ills that we might be able to achieve. Things like something we're affectionately terming an AI hunter bot is something that we're looking at to help law enforcement, help with those social and health-oriented elements, and help everybody. So that's something that we're trying to do that would be an example of where it takes multiple disciplines coming together.
Oh my gosh, only at UCF.
You taking a question?
Yes, let's have one question.
So we're talking about what AI can do, and Dr. Chang just left without completing his thoughts. I'd like to get your thoughts. What can't AI do that we have to do?
So there's always going to be a human element of quality and thinking about what AI is meant to do to serve. And there's a number of things that I'm still seeing a lot of work to do in there in being responsible, responsible AI, the AI that's explainable, AI that is democratizing rather than excluding. Those are some of the things that we have as social goods. How can you instill trust? Maybe blockchain and other technologies help with that too. How can you make sure that it's safe and secure for everyone too? And maybe that's where cybersecurity comes in. So it's not just AI standing alone, it's AI with a human oversight element and AI with other technologies that may be complementary and that are still sometimes novel and new too, all coming together to work for the good of humanity and the morality, the ethics of that too. There's a lot of issues and blockage in that with AI as it stands right now. It all comes down to the training. There's an old saying from a long time ago in computation: garbage in, garbage out. So how we train these? Do we train these with the right humanity, the right morality, the right ethics, the right compassion? Those are all things that it still has a lot of work to do in my mind.
No, absolutely. I keep telling many of my friends in DC and in California, the age in technology is for humanity. I see some of the clinicians here, and I know you do it every day, and medical students. Don't ever